Good afternoon, everybody, and welcome to the Improvement and Innovation Showcase, Think Sepsis, Improving Care, Saving Lives. My name's Katie Billing. I'm the Executive Director for Consumer and Clinical Partnerships here at the CIH, and it's my pleasure to host today's session. Before we crack on, I just want to start by acknowledging and paying respect to the traditional custodians of the place that I'm sitting right now in South Australia, which for me today is the Kaurna people. I'd also like to acknowledge the other lands that people will be joining this session from today. For me, I guess it's important to recognise the First Peoples of Australia as the longest continuous living culture in the world, and also to recognise the injustices of the past. I'd also like to take the opportunity to stop and recognise that Aboriginal people do not experience equity and equality of rights and life expectancy as other Australians do. And at the same time, in doing so, I really want to acknowledge with the greatest respect the resilience of Aboriginal people in the face of adversity. And I think in the context of today's presentation, that becomes a really important consideration. My job to do some housekeeping before we start. So particularly for those who haven't joined us for an Improvement and Innovation showcase in the past, this session's been preset to keep your mics on mute and the video feed turned off by default. Later on, we'll have a Q&A session, and there's an opportunity there for you to be able to turn your camera on, and we'd love to see your smiling faces when we get to that Q&A part. So only the presentation component of an Improvement and Innovation showcase is recorded and published, and we'll turn the recording off when we get to the Q&A later on. Important for me to also mention, before I get into trouble, that after the Q&A, there's also a quick survey for you to complete, and that helps us keep ourselves accountable and make sure that we do what we said we would do. Would appreciate you just taking a couple of moments to fill out that evaluation. So really quickly, I'm just going to indulge and make sure that everybody knows who we are here at the CIH. So our vision at the CIH is together creating health and prosperity for all. And I guess we're doing this today by helping the sector come together to share stories, but also to imagine new ideas for better healthcare. I guess we recognise that better isn't always excellent, but certainly for us, it's about measuring what we're doing so we can really understand the impact of the change that we're making and the impact that that's having. So Improvement and Innovation Showcase has been running for a few years now, and really it's this question of what if the big idea was connecting all of the small ideas. These sessions are really driven to be a 40-minute session so that people can come along if they're able to, step out of whatever it is that they're doing otherwise and participate in a Q&A and a conversation afterwards, but also recorded. So if you're not able to get here, you can come online whenever. It's about bringing healthcare teams together and really keeping it simple, creating a space where people can explore what others have learned. It's not always about saying we've got the answers or we've found the very best of the best, but it is absolutely about creating a space where people can share stories. It doesn't necessarily, when we say keeping it simple, doesn't always mean that we're at the point where the presentations are at an academic level or where people might be out presenting at formal conferences. This is really about keeping it real and having an opportunity to share stories. We've had great presentations where people don't even have a slide deck, but they're just able to show up and tell a story. So it's really important to us that we're keeping it real. So just again, a quick plug, if you have a story to tell, so you've succeeded in solving a problem, we've learnt something whilst trying, or if there are themes that you think we might like to explore into the future, shout out and let us know. We'd be really happy to hear from you at the email address that's here, and I'm sure throughout the presentation and probably behind my head as well, I suspect. So without further ado, welcome to the first of the first episode in our sepsis showcase. So this theme around Think Sepsis, Improving Care, Saving Lives is really in recognition of sepsis as a life-threatening complication of infection. And really, this can affect people of any age. We know that early recognition is critical. The sooner sepsis is identified, the sooner life-saving treatment can begin. Early detection reduces complications and shortens hospital stays and improves survival. Sepsis is a focus for the South Australian health system as of sort of January this year in a new way. And that relates to the way the CIH is supporting the South Australian Clinical Council to have some priority focus areas. So we've been focusing on sepsis for many, many years. In fact, one of the presenters and I were focusing on it many, many years ago out in the local health network. So this is really not about saying that you haven't already working in health systems been focusing on sepsis. This is about aligning the resources and concentrating efforts to improve mortality and morbidity from sepsis across South Australia. And so really this focus area for us in the showcase today is part of being able to support that conversation. So really briefly, we arrived here because we know that unwarranted clinical variation has been identified as a system priority by South Australia's Safety and Quality peak body, if you like, the HCEC, or Health Chief Executive Council Safety and Quality body. And really, their focus is on recognising the impact on safety, quality, equity, and also the system efficiency that this affects. And so at the same time, our clinical council, hosted by the CEIH, endorsed a focus area that they wanted to work on as clinical excellence and safety. And so the planets aligned, and we were able to say, well, actually, if the safety and quality group want to look at improving sepsis across the system, then actually clinical council have said, let's look at clinical excellence and safety. Let's bring these two worlds together and work together to do better. In terms of the why, I'm not going to go through in detail the key statistics, but really just to say why sepsis, because clinical variation is causing harm. And so we know that at the time of sepsis occurring, but afterwards as well, there is harm to the people who we're caring for. We know that there's impacts in relation to mortality, length of stay, utilisation of ICU beds, and also, I guess, ultimately, the long-term challenges for recovery in terms of the long-term physical, cognitive, and the psychological challenges. So over the next month, we have a series of showcases, and this is just the first of the 4 in the series. If you haven't already seen these, we have another showcase on the 12th, the 19th, and then the 26th, just like this one, held in a live session with a recorded session also accompanying that. So without further ado, because it's not my show, I'd like to introduce our speakers for today. So we're joined today by a team of 3 people who are presenting on behalf of the Flinders and Upper North Local Health Network. So we've got Caroline, who is a consumer who experienced postnatal sepsis in 2009, resulting in bilateral lower limb amputations after prolonged ICU and hospital stay. And as you can imagine, this is a really powerful lived insight into how quickly sepsis can progress and why early recognition and treatment really matters. Joining Caroline are Janine, Connell, who's a regional lead for sepsis work group and the Recognising and Responding to Acute Deterioration Committee. Janine's got over 45 years of nursing experience across 3 states, from major trauma centres to remote and rural services, and she's lived in SA for more than 30 years. Janine's a strong advocate and for timely access to the right care as close as home as possible. And we're also then finally joined by Bianca, who's the nurse unit manager of the Renal Unit at the Port Augusta Hospital and an infection control nurse. And Bianca has been a key member of the Sepsis Working Party. Bianca brings 20 years of local experience alongside a personal consumer perspective through her family's experience with sepsis as well. So we're really excited to hear from our speakers today. And on that note, I'm going to hand over to Bianca, who's going to kick off our presentation for today. Thanks, Bianca.
Thank you. As just mentioned, my name is Bianca. I'm from the Flinders Upper North LHN. I'm based in Port Augusta, and Janine, who's with me today, is also in our LHN based about 260 k's north of me in Roxby Downs. So I'd also like to acknowledge the lands which we meet, work, live and play on as the traditional lands of many Aboriginal language groups in South Australia. So for myself, I'm here on Bungala country, which borders on Nukunu country. Janine is coming to us from Cookatha country, which is the lands of my grandson's ancestors. We also respect the spiritual relationship with country and acknowledge their language, cultural, traditional beliefs are a really important focus of their past, present and future. And we also pay respect to the cultural authorities of Aboriginal people in attendance today and emerging and, you know, really striking a chord for Aboriginal people and making sure that language and culture and traditions is maintained across the state. So to talk about sepsis. So as we all know, sepsis is quite a challenge. It's often hidden in plain sight, it can sneak up on you, and it is a life-threatening condition. So through a clinical case review, we noticed we had a small number of patient incidents where sepsis diagnosis and treatment had been missed or delayed. So in 2022, around the same time, the clinical care standard came out for sepsis, we established a work group and worked on some gap analysis to identify areas for improvement. So this included a really fantastic multi-D team with nursing, pharmacy, medical and quality and safety reps, many who are still involved today. We completed the clinical indicator tools to help improve our auditing processes for diagnosed and suspected sepsis presentations across our hospitals. So we had some advantages and disadvantages in that process. Some advantages was that we had Port Augusta, particularly on sunrise sites, which made it a bit easier for us to find that sort of information, while the rest of the LHN was still on paper. So it was quite an effort to try and find that information, obviously being a mixed mode site within LHN. Plus we all know how hard paper is to go back through, and so it was a massive amount of work for a lot of people. So we also wanted to have a focus on consumer resources available through Sepsis Australia, Sepsis SA Health and Safety and Quality, Could It Be Sepsis? So we had a lot of information we could use and work through. So our key objectives became that we identified the need for a code sepsis or a simple localised pathway for clinical staff to follow. So staff are very familiar with code blues, code blacks, code strokes, met calls, you know, and we wanted something simple that really raised that thinking of a sepsis presentation. So we needed a resource or a tool to promote the early identification and notification of potential sepsis. We also wanted to improve our auditing processes, and you know, as I mentioned initially, we had a lot of sites on. We had us on EMR in Port Augusta, with the other sites on paper-based records. So you know, it was quite a cumbersome. I was lucky enough to be in one of the sunrise sites, so I can't really comment on the paper, but I can only imagine how much of a workload that would have been to go through. So we also identified the need for increased lactate testing to ensure earlier detection for potential sepsis. So being in a regional area, we don't all have lactate available through our labs. So lactates, formal lactates actually need to be sent to Adelaide. So it was ensuring that we had a point of care availability at all of the sites. So we also identified gaps in training and orientation for the medical workforce in early sepsis identification management. So we, at the time, and still do have quite a reasonably large locum workforce, and we needed to ensure that any new staff were coming through were upskilled and aware of local protocols and pathways, because having a lot of interstate people come through, that you know, there ends up being a lot of different processes, and we wanted to make sure that everyone was on the same page. So while we do still have a huge locum workforce, and thankfully a lot do come back, so it is a lot easier, but it's still an ongoing issue. So having representatives on our group with whose passion and commitment to effective sepsis identification and management, so dedicated to the and knowledgeable work group lead, which is Janine, who has a massive passion for this subject, and we actually really did get quite good buy-in from our medical and pharmacy workforce as well, which was excellent. So it can be sometimes tricky to get the medical team, again, because of a lot of people working in different areas and between different work sites, but we have got a couple of key medical people who are very passionate about sepsis, and we're very grateful to have them. So we also ended up with presentation from all our sites, which is hugely important, because Port Augusta and Whyalla are having a much bigger emergency department, where we'll go to places like Roxby where you've got a nurse or two and that's all they have. So, you know, it's really important, you know, that we're making sure we're looking after all sites. So, and then as well as mentioned before, you know, there's people like me, and I'm certainly not the only person, you know, staff member that has been affected by sepsis personally. So, and even in my story, it did sneak up on my husband, and it probably was the last thing we were thinking at the time. So yeah, it definitely brings it very home that it can happen to anyone, and regardless of your background. So the draft SA Health Adult Sepsis Pathway was adapted, which is adapted from the New South Wales Clinical Excellence Commission, was out for consultation, although we were still waiting for pathways to be finalised and rolled out on a state level. FUNLHN adopted the draft SA pathway and the SA Paediatric Sepsis pathways in late 2024, because we wanted to get some consistent messaging across all of our sites. So both have been shared with our locum workforce, and one of our first steps through the inclusion of our medical workforce orientation program. So we've also now got a strong education program with our medical workforce, which we can make sure that these important things like sepsis recognition are included in that, and those people are well aware. And of course, now the SA Health Adult Sepsis Pathway has now been released, which is it's, you know, given us another opportunity to make sure that we are re-advertising everything, and you know, prompted us away again to re-looking at our auditing processes and things, you know, so making sure that we're aligning with the pathway. And because we have been auditing for such a long time, it's now giving us a good refocus on actually looking back at where we've come from again. So some of the impacts of our work. So we've now been auditing and diagnosed and suspected sepsis presentations for over 18 months, probably a bit longer than that now, with gradual improvements over time. These results are reviewed regularly by the sepsis work group and shared with our committee. And look, I will say there's still things that do slip through the gap, and it's sometimes not until you have a little bit of a look back. And unfortunately, you know, we do see a lot of presentations that just come in and it's just way too late. So it'd be really good to see if we, how much of that changes over the next 12 months or so, as we start to relook at more and more data. So, you know, there's always still room for improvement. So some of the impacts of our work is that we share our results through clinical staff, through sepsis posters, audit results, clinical handovers between medical and Director of Medical Services. We've also got a very passionate educator, one of our anaesthetists, who every year does an amazing sepsis in service for nursing staff, and really brings it home to everyone, generally as a case study, which is hugely beneficial. We've developed a number of resources to promote and raise awareness of sepsis, early detection and management with our nursing and medical workforce, including banners for our WOWs, which is our workstations on wheels, sepsis pharmacy boxes for our small sites, which I think we've got a picture of these next. So these are our sepsis boxes that we have in the small site. So as I mentioned, there's maybe one RN, one EN on site on duty. So having this sepsis box gives them all the things they need, because I mean, if you're talking your time critical things, we're talking less than an hour. When you're one of two people and you're trying to manage an emergency department and the patients you have on your ward as well, you want things to be as quick and easy. So yeah, these are put together so it's a quick grab and go for those staff, and it has all the information that they need in there to make things easily and readily available. And this is all done off of the guidelines and everything as well. We also have our sepsis posters, which are sent out to the to each of the sites just to let us know how we're going with our sepsis. So, you know, things like, you know, we're getting our cultures in time, or we're getting our fluids in on time, we're getting our antibiotics in on time, you know, and you can see from just on graph that dramatic improvement through those things. So Yeah, so it's definitely improving, which is what we're wanting to see. And people are, even when I was in ED the other day for something, like the sepsis is getting thought of really quickly as well, and people are asking that question early and acting as if it's a sepsis and then stepping away, which is really what we're wanting to see. And of course, in all of that, we've also got our order set on Sunrise. So we are now all on Sunrise sites, which is hugely beneficial, which is great now because we can have really consistent messaging across all of the sites. And, you know, we've had a huge amount of now education on the sepsis order set. So which just, again, is that another tool that makes everything so much easier for us, because everything that we need to do in a sepsis presentation is all there and ready for us. So yeah, so this is our trended order data from July 2024 to September 2025. So, you know, again, a few things, little ups and downs, but generally and overall, it's definitely a positive. So moving in the right direction, but always can do more. So that's it from me. Are we holding questions at the end, I'm guessing? So we won't do any questions.
Yeah. Yeah. Thanks, Bianca. And I think now we'll hand over to Caroline. Beautiful.
Thanks, Katie. Okay, hi everyone. So my name's Caroline Dingle. I am an employee of SA Health, but today I'm here as a consumer, so it's very much a personal story. I had sepsis in 2009 after the birth of my third child. I can't actually remember a lot about being acutely ill with sepsis. There's almost a 3-week period that I don't remember, which is probably a very good thing. So to prepare this talk today, I looked through a series of emails my husband sent to our family and friends, along with some of my early clinical notes. And I've pieced these different sets of information together to show a picture of me getting sicker and sicker from both the human perspective and the clinical measures that I could pull out of my notes. I'm really aware that I've cherry-picked from my clinical notes, as there are lots of them. I have some very big files out there, and that identifying sepsis is not always that easy. And I think, as Bianca said, hidden in plain sight is a really good way to look at it. I'm also aware that some of the barriers that I experienced in getting an accurate diagnosis would likely be exacerbated if I had been in a rural location. So if I'd had to wait a long time for a retrieval to a major hospital, I probably wouldn't be giving this talk here today. So I was very privileged to live near the CBD and to have medical members of my family advocating for me along my sepsis journey. So I apologise in advance for breaking some of the rules of PowerPoint and having swathes of text, but you can read along or listen as suits you as I talk through this. So day one, my daughter Lara was born after a really uneventful 80-minute labour. And I should say here that having had 2 fast and uneventful labours before, this was entirely what was expected. And this photo is a couple of hours after Lara was born. And my sister, who's a GP, looked at this photo some years later and said, yes, you do look like a person who's about to become seriously ill, but you also look like a woman who's just given birth. And I think that speaks to the difficulty of identifying sepsis when there are other factors at play. I wasn't feeling great after the birth, and apparently I had a fever of 38.8. But unfortunately, this was June 2009, which was it was the week that swine flu hit Adelaide. So there was a lot of anxiety about swine flu, and the hospital's major concern was around infection control and a potential swine flu case. So day 2, I remember a little bit of day 2, but none of what is written in this email. Apparently the baby is flat and I'm in a lot of pain, and I still got a little bit of a fever, and they've given me some morphine to manage the pain. My main memory of this day is actually of my brother-in-law coming to visit late in the afternoon. He's also a GP. and him repeatedly asking the nurses, has this baby seen a paediatrician? When is the paediatrician arriving? And being very persistent with the nursing staff, asking again and again. And my thoughts, which is the last thing I remember, is thinking, oh, Chris, just go home. I'm tired. I want to go to sleep. But he kept hanging around. So his medical spidey senses, as I'll call it, were kicking in, and he'd worked out that there was something wrong with the baby before anyone else in the hospital had identified that, and luckily so. She was very ill and taken to the Women's and Children's late in the evening of day 2, when she's around 29 hours old, and admitted to intensive care there. And that's the last thing I remember, is day 2 for about 3 weeks. So moving on to day 3, on the left is a really heavily edited version of the original email, but it shows that whilst Lara, my daughter, got antibiotics as a standard practice when she was admitted to the Women's and Children's, the potential diagnosis for me kept changing. So swine flu was ruled out first, my gallbladder was investigated and then ruled out. My brother-in-law and another doctor at the hospital suggested maybe a bacterial infection. But then there was also this possibility of a blocked bowel, and so I was sent to surgery for a blocked bowel. There was a bit of bad luck in here. There was a broken CT scanner at the hospital I was in for the labour and delivery, and there was a delayed retrieval to take me for a scan at another hospital and then returning to the original hospital. But it's clear from those clinical notes on the right that I am deteriorating, and I don't get antibiotics until sometime between 6 p.m. and midnight on day 3. It's not actually clear what time I got it from my notes. There's a nice question mark next to it. So my diagnosis was essentially old-fashioned childbirth fever from a strep A infection that killed many women up until the mid to late 19th century, when hand washing became a more normalised practice. I was doing a little bit of digging and I discovered that childbirth fever killed 2 of Henry VIII's wives. So that's a third of his wives, showing just how common infections in childbirth used to be. I did ask my sister what she wanted me to get across in this presentation, because I very much feel like she lived through this a lot more than I did. And she said 2 things. Firstly, listen to the family. They know what's normal for a person and what doesn't seem right in terms of their behaviour and how they're feeling. And the second was more of a medical perspective, which was think of the worst possible diagnosis, even if it's the most unlikely, and then work backwards from there. So by day 4, Lara and I are both clearly in a lot of trouble. These photos are from early July, where we're still both very sick and in intensive care and in different hospitals, adding to the complexity of the situation. And on the 2nd of July, which was my 37th birthday and 9 days after Lara was born, I had both my legs amputated below the knee. And I've just got the cake in there, which apparently the nurses enjoyed for comic relief. But I subsequently lost quite a lot of my bowel, had a hysterectomy, and I've got lots of scars from skin just sort of stripping away from me, a bit like a burns patient. So in many ways, sepsis didn't end well for me, but I was alive. So what did go well for me was that I had intensivists who had seen postnatal sepsis before. They had treated 3 other women before me, but unfortunately all 3 of those women had died. So I'm very conscious of the fact that I lived because of the lessons that they had learnt from treating 3 other women. The other thing that I had in my favour was a really cohesive team, and as an organisational psychologist by profession, when I was less sick, it was really interesting to note the amazing sense of equality in the team that was looking after me and the way that everyone was involved in my care, including the cleaners, who felt that they had a really important role in cheering me up and chatting to me whilst they were cleaning my room once I was conscious, which was lovely. Post-sepsis, I spent 3 months in Wakefield Hospital and 3 months at the repat, learning to walk again. So here's a photo of me standing on prosthetic legs for the first time. And we've got a physio and an allied health assistant there, and there's also a prosthetist in the background. So I think it really sort of paints the picture of how many people are involved in the recovery of someone who's had a serious situation with sepsis leading to complications such as amputation. So it really does take a team to get someone quite literally back on their feet. And the other photo, which was my main motivator for getting well, was having 3 children at home. I had a race against time to start walking before my daughter did. She made that a little bit tricky by starting to walk at 10 months. But this is a photo of the kids, their first photo together after she came back from hospital, and because she received those antibiotics early, she's been a normal, healthy baby and hasn't had any complications. And to some extent after this, things go pretty much back to normal. I had a really good cheer squad, lots of family and friends who could support me, which was great. And I had a really good relationship with the doctors and nurses who treated me. In fact, I remember a conversation with my original general surgeon where he said that I needed to be really realistic and expect recovery from this serious illness to take at least another year or so. So that set those really realistic expectations up front. But I still occasionally will meet a doctor who seems really shocked about what happened to me, and they'll say, "This happened in Australia, are you sure?" As if this is such an unlikely thing when, you know, we've heard from Bianca and Katie just how common sepsis can be. It was only a few years ago that I started interacting with sepsis support groups, and that was when I realised that other people hadn't had sepsis explained to them as well as I had and didn't know what to expect after experiencing sepsis. And that concerns me a lot because there's a lot of gloom and doom in these online forums around sepsis, and that sense that no one understands the weird symptoms that they've experienced, and lots of comments like your life will never be the same again, you know, you'll be tired forever, etc., etc. And sometimes I really want to chime in and say, you know, that's probably not sepsis, that might be your diabetes or your heart failure, and please see a doctor about that symptom. But what I think is often behind a lot of these comments is that sense that they feel that they haven't been listened to, perhaps either at the start when sepsis might have been missed, or when they were discharged and didn't understand that they had had a serious illness and that it would take them a while to recover from this. And I know that sepsis is a really complicated concept to understand, but I think it's really, really important for those people to understand what has happened to them and feel that they can ask questions about what happens next and get answers to them. So that's the end of my presentation, and I'll hand back to Katie. Thank you.
Caroline, thank you, and thank you so much for sharing your story with everybody in the call today. I'm very, very grateful to you for sharing so openly with us all. So yeah, great appreciation to you, and also to Bianca and to Janelle as well. I'm just